Hello, everyone. Good morning, good afternoon, good evening. Thank you for joining us today. We'll just wait 1 or 2 more minutes to allow folks to join the session, and then we'll get started. Hello, everyone. If you've just joined us, thank you for joining. We'll wait 1 more minute and then we'll kick off the session.
Ja, das ist gut.
Okay, we'll get started with some introduction or some quick announcements to start the session and give folks a chance to trickle in as we get started. Thank you for joining us today for this session on costing and budgeting as part of our webinar series for the Washington Healthcare Facilities Initiative and our community of practice. So a few announcements. These got sent out in our most recent newsletter, but in case you missed that, there's a new course, a new open WHO course on gender equality, disability, and social inclusion for Washington Healthcare Facilities. We'll send out registration information for this again during our newsletter this month. But that course is freely available, and we encourage you to join online if that topic is of interest to you. To recap past sessions, this webinar is serving as almost a part 2 of a previous webinar on costing and budgeting that occurred back in February of this year. That session was recorded and is available on YouTube on the WHO and UNICEF Washington Healthcare Facilities YouTube page. As a reminder, the content for that session, there was a brief introduction on what are costing and budgeting. Then we saw a case study presented on utilizing cost data to advocate for financing for WASH and IPC, as well as a case study on budgeting and advocacy for WASH operations and maintenance in Nepal. So if you missed that session, I recommend that you watch that. It's available on YouTube. We sent out links for this session, resources discussed during the session, as well as the link to the YouTube video in our past newsletter. And we'll send that out again in the newsletter that recaps this costing session. So our agenda for today, we have 3 very exciting case studies lined up for you. Our first case study will be a study on the costs of inaction from inadequate WASH and healthcare facilities in sub-Saharan Africa, and this cost and benefits analysis. We then have a case study on participatory life cycle costing for WASH and healthcare facilities. And then last but not least, our third case study is on costed improvement plans for Washington healthcare facilities in India. Then we have the second half of the session will be a moderated Q&A session. Some of you submitted questions in advance when you registered, and so we'll ask some of those questions. And during the second half of the session, we'll offer the opportunity for folks to unmute, to interact live with the speakers. We also have the chat going, so feel free to use the chat during this session to add your questions, to comment on the presentations as they're ongoing. We want to encourage interaction during this session and have a chance for you all to meet each other, to meet our speakers, and to get in and really discuss this topic. So please use the chat. Please prepare your questions, but do hold them till the end. We'll be taking Q&A for all of the case studies after all three have been presented. Without further ado, I'm standing between you and our very interesting speakers. So I'll introduce our first case study speaker. Today we have Guy Hutton, who is a development economist, currently working as an independent consultant from the UK. In relation to this presentation, he started out as a health economist. Over his 30-year career, he has held positions at UNICEF, the World Bank, the Swiss Tropical Institute, and several UK universities. His fields of interest are WASH economics, financing, costing and affordability, and WASH systems analysis and strengthening. Guy, the floor is yours.
Thank you, Darcy. Sorry for a bit of a mouthful introduction. So I'm very happy to be presenting this study. So this is a collaboration with the World Bank, who initiated the development of a methodology and conduct of the study in 9 countries. And WaterAid supplemented this with an additional 5 countries and have recently published 7 country briefing documents, which we can make available in a link in the chat. So unfortunately, some of my co-presenters can't make it here today because they're double booked, but I think Mary Ashinio is joining us. So what is the issue? Healthcare-associated infections are a global problem. In Africa, around 10 to 20% of inpatients pick up an infection they were not admitted with. I'm sure you're very aware of the issue. Even in Western or developed countries, this happens quite often. Picking up a healthcare-associated infection leads to further illness, longer hospital stay, excess costs, and sometimes death. So as well as patients, they also impact care workers who are more exposed to these infections, therefore reducing availability of already stretched staff. These days we talk a lot about antimicrobial resistance. In Africa, in sub-Saharan Africa, there are rates between 20 and 80% depending on the infection and the drug. And this obviously leads to a longer hospital stay, worse health outcome, and having to use more expensive drugs and diagnostic tests. So it adds more to the burden on the health system. So question, what causes the majority of healthcare-associated infections? Well, that's why we're here. It's the lack of access to clean drinking water, safe sanitation, poor practices of hand washing, and poor infection prevention and control, and poor solid and hospital healthcare waste management. The pathways are very complex, and some have attempted to map out the pathways, but we bundle them together for the purposes of this study. So why this study? WASH in healthcare facilities remains below 50% on average in Africa. Most African countries have policies and plans for IPC and for control of AMR, but they're poorly implemented. So we need to raise, last click on the slide, please. We need to raise the profile of healthcare-associated infections, what they're costing health systems, what they're costing countries, and how cheap or how costly it would be to prevent them. So you can find more on the results and methodology in this World Bank working paper. And we're in the closing stages of a submission to the Journal of Hospital Infection. So hopefully that'll come out in the middle of the year. So what are the study objectives? To estimate the financial and economic costs of healthcare-associated infections to health systems and patients in 14 countries of sub-Saharan Africa, covering these areas. We can compare the costs of inaction with the costs of implementing to estimate the cost benefits. And so we also can see what proportion of healthcare costs are due to these. What is the percentage of GDP for the overall costs, the economic costs, including costs of premature mortality and productivity losses, and eventually to estimate the benefit cost ratio. So the methods are a cost of illness methodology. A model was constructed with a whole host of variables. Essentially, this is the sort of simplified version of the methodology. The healthcare cost is the number of inpatients times the HAI rate, times the additional length of stay and treatment cost for patients. Productivity loss is number of inpatients times HAI rate times additional illness days times daily value of time. And mortality cost is using the case fatality rate and the value of a life, which has been extrapolated to each country based on their economic level. So the data sources are various, Ministry of Health reports, literature reviews on which included meta-analyses and systematic reviews, cost studies from the IHME, which had sort of good quality cost studies, and from the World Bank, various economic variables. So in terms of the results, this is the total number of HIIs estimated in the 14 countries, and on the right axis is the number of deaths. Around 500,000 deaths in these 14 countries are estimated, and around 10 times the number of infections. As you see, it's a very high case fatality rate. The total losses are around $13 billion per year, of which healthcare cost is around 2.4 billion. You can see Nigeria dominates because of the population size, also Kenya and Ghana having an important contribution. Sensitivity analysis was conducted to see which variables had the biggest impact according to the ranges we used. And the mortality impacts were particularly had a large difference when we used different values. So next slide, please. In terms of the cost as a percentage of GDP, that's in the blue bars, up to 2.9% in Malawi. Wow. And for healthcare costs, as a total percentage of total health spending, it was from a small lowest amount in Mali up to 13% in Madagascar. So, of course, these estimates are approximate based on the unit costs we could gather. These studies obviously need to be conducted at some future point in more detail at the country level. So in terms of the cost benefit, the total cost per capita is $15.7. The healthcare cost 2.9 per capita. So if we prevent half of HIIs through basic wash, IPC, and waste management, it could save almost $8 per capita and in economic costs and $1.45 in healthcare costs. And comparing with the approximate $1 per capita for basic wash, IPC, and healthcare waste management, the healthcare costs can be saved from this intervention. So it's positive. Certainly not all the impacts were included, but it's a very positive result in terms of what you can expect to get back in financial returns. I won't talk through this slide. This gives more detail on lower middle income versus low income countries, and these are available in the paper. So we've demonstrated major hidden costs of healthcare associated infections in sub-Saharan Africa. A package of simple interventions can prevent a major proportion of cases, thereby saving lives and reducing exposure of health workers. There are several weaknesses, both data and methodological. We tried to be conservative with the estimates, obviously there's some uncertainty, but I think the main conclusions would hold that the healthcare associated infections are a massive burden on health systems. There is a tool under development, and so we can apply this in other countries and even fine-tune the estimates in study countries if we have better data inputs at some point in the future. Thank you. That's all. Look forward to your questions.
Great. Thank you so much for that presentation, Guy. If you have questions, please do put them in the chat now or write them down and hold on to them until the Q&A session at the end. We would be delighted to take them then. In the meantime, we have our second case study presentation. We have Francisca Sarmento and Kyla Smith from WaterAid. Francisca Sarmento is WaterAid's program manager from Manafuhi Municipality, Timor-Leste. Over 10 years, Francisca and her team have been working in communities, schools, and healthcare facilities in Manafuhi to improve access to safe water, decent toilets, and increase hygiene behaviors. Kyla Smith is the senior WASH manager and health at WaterAid. She has 15 years of experience working in international development on WASH programs. Kyla supports WaterAid's programmatic work on the integration of WASH in health, including WASH in healthcare facilities, health programming, and systems. Francisca, I know you were having some internet connectivity issues this morning. Are you with us?
I think she's still stuck in Zoom purgatory.
Still stuck in Zoom purgatory. Okay. Kyla, are you good to kick off this section while Manal and I and the team work to see if we can get Francisca back online?
Yes, sounds great. Thanks, Darcy. Hi, everyone. Thank you to the organizers of the COP for this invitation to share about some of the work WaterAid has been doing on participatory life cycle costing for WASH and healthcare facilities at the subnational level. My name is Kyla Smith, and I'm hopefully joined by my colleague Francisca Sarmento from Timor-Leste, WaterAid Timor-Leste, who will share some details of their work with the municipal government on costing for WASH and healthcare facilities. Next slide, please. So when WaterAid is working with government on life cycle costing, we do so across the 6 components shown here, such as capital expenditure, operation maintenance expenditure, and so on. And what we'll do is we'll apply all of these cost components to each of the 5 WASH services in healthcare facilities: water, sanitation, hygiene, environmental cleaning, and healthcare waste management. And we do this as we've seen that as part of helping to ensure sustainability of services. It can help those involved understand the funding gaps that exist to meet national standards on WASH and healthcare facilities and what's needed to keep the services running. It also helps improve planning and budgeting for WASH and healthcare facilities and can support advocacy efforts for accelerating action. And finally, it can also help highlight issues with the flow of funds and how they are accessed and used at district and down to facility level. Next slide, please. So WaterAid has now been working on life cycle costing in multiple countries, including Ethiopia, Ghana, Uganda, Timor-Leste, and others at district municipal level, within healthcare facilities, and also at the national level, supporting development of costed roadmaps. And depending on the scope of work and the context, the process will be adapted, but it will roughly follow these main steps. So the first step here is to be clear on the scope and target of the life cycle costing work. Are you aiming to do it at national, subnational, or facility level? Is it looking across all 5 pillars of WASH and healthcare facilities or other components as well? How many years will be considered in the analysis, and so on? Ensuring as well that this work and the process that you follow aligns with the existing planning and budgeting processes happening in country. Well, then, as a next step, we'll look at either collating existing data and filling in any gaps that are needed for the analysis, or conducting new data collection. next, we'll work with key stakeholders to identify reference unit costs for different WASH facilities. So these, along with the current WASH service data, are then all filled into an Excel-based tool that we've developed that looks across all 5 pillars of WASH and healthcare facilities and can be used to calculate costs for the upcoming years and looking at different scenarios as well. As a next step, we would host with the government a participatory workshop with sector stakeholders. And here it's really important to ensure the right people are in the room, both from the facility and district level, and also from various departments, including, for example, finance, procurement, engineering, staffing, etc. We found that in these workshops, after providing an overview providing an overview of life cycle costing and the components, it's also very helpful to do a paper-based exercise with participants to run through the calculations before showing the Excel tool. So this has helped participants have a sense of where the numbers are coming from and how the calculations are being made. We tend to only do a session towards the end of the workshop with the Excel sheet tool once participants are more confident with the process and the methods followed. And then from here, the tool can be used to trial different scenarios for the coming years and adapted each year based on changes in planning. A final session in the workshop that's helpful to have as well is to have an understanding of where the funding is currently coming from, what are the gaps, and what are possible additional sources. So I'll do another quick check to see if Francisca Sarmento is here with me from Timor-Leste and if her audio is working to share about our work in Timor-Leste. Manasika, can you hear us?
She's not present on the participants,
Okay.
so I think she's still unable to join us.
In that case, my colleague Fraser, can I pass it over to you? You might want to do a quick introduction as well. Sorry, Fraser, over to you.
Happy to do so. Thanks, Kyla. Good evening, good morning, everyone. My name is Fraser Goff. I'm WaterAid Australia's Regional Technical Lead for System Strengthening. And I worked with Francisca and the Timor-Leste team on our lifecycle costing for WASH and healthcare facilities. And so, yeah, I will present on behalf of Francisca. So as some brief background, in 2020, the local government in Manukau municipality in Timor-Leste created their first municipal WASH strategy that covered healthcare settings, schools, as well as community contexts. To help achieve the strategy, WaterAid and municipal authorities co-facilitated a district-wide assessment of WASH in all 27 healthcare facilities in the district, followed by a participatory costing workshop involving stakeholders from government, community, and non-government. Next slide, please. We costed basic service levels for all 5 domains for each healthcare facility in the municipality, following the guidelines for WASH and healthcare facilities recommended by the Joint Monitoring Program. Within the analysis, we considered the costs for initial installation and rollout of new facilities required to meet those standards, ongoing operation and maintenance costs, rehabilitation costs when facilities reach the end of their expected life span, as well as personnel expenses, training costs for environmental cleaning rollout, as well as municipal support costs for planning, monitoring, and oversight. We estimated that the total cost of providing and maintaining WASH services in healthcare facilities in the municipality was almost $1.5 million between 2022 up to the year 2030. The largest part of this cost was determined for salaries for staff to sustain the services. We also disaggregated the costs. We calculated the costs for every healthcare facility, but we also ran average numbers for healthcare centres and health posts, identifying that each facility will need, on average, $15,000 for capital expenditure, but ongoing annual costs of $10,000 per community health centre and $3,000 per health post. Based on the population of Manawatu municipality, this equates to approximately $7.74 US per person for the initial investment, and just over $2 per person per year for ongoing costs. Next slide, please. We also calculated the total annual cost to the municipal government for WASH in healthcare settings. This calculation considered the expected timelines according to the strategy for upgrading infrastructure and rolling out new protocols and procedures, as well as considering the lifespans of infrastructure and facilities. Next slide, please. So after sharing the life cycle costing results with various municipal government departments, not just the WASH and health sectors, the municipal government then presented the results nationally to the Ministry of Health, as well as to the Vice Prime Minister. Senor Arantes, the municipal administrator, also presented internationally at a regional WASH and water conference in Brisbane, Australia, on these results. As a result of sharing the results, we've begun to see some changes and impacts in the health system. For example, the annual budget developed by Manawatu Municipality Administration has taken into account the results of the costing, and the Municipal Department of Health have used their annual budget to fund WASH upgrades for the first time. Other government departments have invested their own funding in operation and maintenance after seeing the importance of those recurring investments as part of the process. Recently, the National General Direction of Rural Community Housing has used the results to develop plans and budgets for implementing a new WASH program in communities, healthcare facilities, and schools as part of a new community housing program. Next slide, please. Some of the lessons learned from undertaking this participatory analysis. Firstly, our intention was to improve the evidence base for finance allocations for WASH in healthcare. However, we also identified through the process that budget setting is highly political. We encountered challenges such as the municipal government having limited autonomy to set their own budgets, while at the national level, national budgets were often decided on the basis of political priorities and party politics, rather than based on costing and data and estimates. Changes in government since the costing analysis have also meant that some of the champions of the costing process have changed positions and are no longer in positions of budgeting authority. Another challenge identified was that within the Ministry of Health's budgets, there is no budget code for WASH. So tracking investments to compare trends over time is complicated and not as transparent as we would like. We also found that by bringing different stakeholders together in the participatory process, we were able to develop a shared understanding of the costs and financing gaps among stakeholders. However, the roles and responsibilities of who is responsible for funding those gaps still remain unclear in policies and in practice. In future costing analyses, we also noted that the actual costs of construction, operation, and maintenance will vary based on who is funding it. For example, the costs for government are not likely to be the same as when implemented by an organisation like WaterAid, as well as procurement processes and the scale of implementation. Constructing at a municipal scale may lead to some cost efficiencies. I'll end there, but we do have reports on this process and for other countries that Kyla's explained available on our website. Thank you.
Thank you, Fraser. Thank you, Kyla, for that presentation. Up next for our third and final case study presentation of the day, we have Dr. Soman Saha. Soman is a professor and dean at the Indian Institute of Public Health, Gandhinagar, Gujarat, India. Soman holds a PhD from the University of Melbourne, Australia, and dual masters in public health from the University of North Carolina at Chapel Hill, and health management from the Indian Institute for Health Management Research. He leads the Center of Excellence in Nutrition and Health Technology Assessment Regional Resource Center at IPHG. Dr. Saha, the floor is yours.
Yeah, thank you. Good morning, good afternoon, good evening to everyone. So I'll be joined with Dr. Deepak Saxena, who was the principal investigator for this entire work that I am presenting with the costing part of it. So what we did in 2019, where we were invited by the state of Assam to through UNICEF to basically assess the costed to develop a costed improvement plan for making the healthcare facility, public healthcare facilities, WASH compliant. This is part of a larger exercises which had got, 4 objectives. One, to undertake assessment of the current status of WASH in selected the healthcare facilities from 7 districts, 6 aspirational and 1 UNICEF focused district in Assam. Develop a costed improvement plan for improving WASH in healthcare facilities among those 7 districts selected healthcare facility. Develop an ongoing mechanism for monitoring and tracking the improvement of WASH in healthcare facility in Assam, and generate advocacy knowledge products for stakeholders at various levels for improving WASH in healthcare facilities. What I'm presenting today is the second objective, which is developing a costed improvement plan for those 7 district healthcare facilities from the 7 districts, and the next slide, 60 healthcare facilities from those 7 districts of Assam were selected for the intervention, for the assessment. Next slide, please. Yeah, so how we developed this package of intervention? First, we did a qualitative assessment of the status of WASH practices in those healthcare practice facilities. This were done through roundtable meetings with different stakeholders and program managers. We did key informant interviews with hospital managers, administrators, healthcare providers, cleaners to understand their WASH practices. We also want to mention here that these entire packages that we have designed were part of a long effort that IPHG colleagues have prepared, which is called WASH-FIT. And using that WASH-FIT toolkit, a baseline assessment of WASH in healthcare facilities were done. This was done through walkthrough, need assessment based on review of existing documents, and also microbiological surveillance system. Based on this baseline assessment, a training of trainers were done for healthcare workers. The training of trainers included district level and block level healthcare managers, as well as training of healthcare workers by those trainers who were trained by IPHG team. This helped us to develop an estimate of the resource envelope from a systems perspective. This entire thing was done from a systems perspective. And I'll explain how we have done it and what are the variables in the next few minutes. So we estimated what would be the resource or what would be the cost for making those facilities, 60 healthcare facilities from 7 districts of Assam state, WASH compliant. This followed stakeholder consultations. And then the overall objective was that after completion of this assignment, we would do an inline assessment to again following the same methodology that was done in baseline to understand what were the progress for those facilities in terms of their whether they are WASH compliant. So this was the part of the plan for developing a costed improvement plan for the facility. Here in this talk, I am only presenting how we have developed the costed improvement plan, and not necessarily the entire how we have done microbiological surveillance or inline assessment part. So those part I will leave for interest of the time. Next slide, please. Yeah. So how we have done the costed improvement plan? First, in the first step, we identified different domains that would be important for making those facilities WASH compliance. We identified 5 domains. The domains are finalized on the basis of consensus among WASH team at IIPHG and UNICEF Assam team, as well as the National Health Mission team of the Assam state. Based on the domains, we did gap assessment for each domain to assess whether those facilities are WASH compliant and how far away from WASH, what would take to make those facilities WASH compliant. In step 3, we assessed cost estimations to fill those gaps, and I will explain in a few minutes how we did the cost estimation. And finally, we developed a costed improvement plan. Next slide. Yeah. So these were the 5 domains which were identified. The 5 domains include human resources, cleaners. So a long period of our work shows that cleaners are a very, very important part of making any healthcare facility WASH compliant. So first thing that were needed were that do the facility have enough cleaners? Second step were infrastructures, toilet and hand washing facilities at different departments. Third were cleaning supplies. Fourth was infection prevention and control equipments. And fifth were biomedical waste management practices. So these were the 5 domains in which we assessed those facilities to understand what were the gaps to make those facilities WASH compliant. Next slide. Yeah. So how did we do the gap analysis? So these were the list of these types of those facilities. This facilities varied from very small public healthcare facilities which were available at the farthest point to district level hospitals, which were essentially secondary and tertiary healthcare facilities. So gaps were identified in, again, 3 parameters. This is as per our India's assessment parameters. 0 as in which facility, which were the domains in which major repair would be required. 5 which are partially compliant, which means that there are minor repairs would be required, and 10 which is full compliance, which is no repair would be required. And in the next slide, please. So here I'll explain you how we did for each of those 5 domains assessed. Human resource gap. As part of our KAYAKAL, which is a national guidelines for making facilities for basically makeover of all facilities, including WASH practices, it recommends 1 sanitary attendant or cleaner for 2 hospital beds. So according to that guideline, we assessed how many cleaners would be required if we have to make those facilities WASH compliant. So that was first thing that was important for human resources. Second were toilets. As I said, the 0, 5, 10, that is fully compliant, no compliance, partial compliance, or full compliance. So according to that, we have assessed those facilities. Next slide, please. So assessed whether the toilets would require major repair, minor repair, or no repair or maintenance. Similarly, in the next slide, we have done similar assessment for hand washing points as well as IPC equipments. And in the next slide, we did this for, okay, I have not presented for biomedical waste management practices also. We have done similarly 0, 5, 10. This is not presented here. Once we have done the gap assessment of these facilities, the next step were to prepare a cost estimations. So for doing cost estimations, what we did were that we consulted the PIU or project implementation unit at Gujarat state and assessment of private hospitals to understand how much would it take to, for example, if a toilet needs partial repair, minor repair to a major repair, how much would it cost? Okay. Similarly, for cleaners, we took into minimum wages for unskilled employee using the Government of India and Government of Assam's minimum wage norms for unskilled employee. We assessed how much would it cost if we have to engage cleaners. The cost that's obtained, much like my last, the case 2 that we have all heard, we have bifurcated the cost into 2 parts: capital cost and recurrent cost. Capital cost including cost of infrastructure, boiler, autoclave equipments. Recurrent cost include cost of HR, cleaning supplies, chemical HLD, and biomedical waste management practices. Next slide. So based on this, we calculated, we developed a costed improvement plan using the upper level estimates of cost were considered for developing the costed improvement plan. We calculated capital cost and recurrent cost for a year. Next slide, please. Okay, so this is a summary of where I will also present both the capital and recurrent costs, just like you have seen in the case 2 in the next slide. But in this slide, what I want to explain you is that among our 5 domains that we have presented earlier, we have started with which domain where we felt that major cost in were required. It was the human resources. Most of the cases, they were relying on contractual part-time cleaners, because cleaning is something which looked as a job not well taken by employees. So they hired, the facilities were hiring part-time cleaners, but that is against the norms. What we found out is that human resource were the most cost-intensive part to make those facilities WASH compliant, followed by cleaning supplies, as well as other things like biomedical waste management infrastructures or other equipment, IPC control equipments. So this was what we found out. In the next slide. Yeah, here I am presenting among the different types of facilities, the 60 healthcare facilities. What are the average capital and average recurrent cost to make those facilities WASH compliant? Now, if you see and this is also I was referring to the last presentation in the case 2. Again, here you see the average capital cost were more or less, similar. There were no major capital requirements, upgrade requirements, which we found out. But what was more important were the recurrent cost. And as you have seen in the last slide, human resource were the most intensive things, and that is where you can see the most cost. District hospitals, which were among the facilities assessed with the most, they are 300 to 500 bedded hospitals, secondary care centers, and the referral center at the districts. So these were the centers where the most of the costs were required. And state dispensaries or subsidiary health centers, which were more frontline health posts, needed less cost intensive. These results were presented to the National Health Mission, Health and Family Welfare Department, Assam, and they basically used this data to make a case for making healthcare facilities WASH compliant in the states of Assam. So this was a very fast effort where public health facilities, there were an effort made to basically secure resources to make public healthcare facilities WASH compliant. So next slide. In summary, what we found out were key messages from our work where major investment needed in recurrent cost. We need to invest in human resources, especially the cleaners. Water supply were an important issue. Many cases we found non-available and non-functional water points for hand washing. The quality of water was poor. 50% of samples were positive for fecal contaminations. Remember, as I said, we also did microbiological surveillance. The gaps vary by type of facility and individual requirements. In Indian scenario, in public healthcare facility, there are system of untied funds which are not tied to a particular budget heads. So what we advocated were that more use of untied funds so that facilities can make decisions based on their individual needs. But along with resource allocation, what is required is delegation of authority so that they can take better decisions, and needed trainings on biomedical waste, which were very limited. And there is this need for creating a routine monitoring and microbiological surveillance to prevent hospital-acquired infection and disease transmissions, particularly during the public health emergencies. And remember, this is the exercise which we have did just before COVID first wave came in India. So many of the lessons that were generated from this work were later on also used for addressing the COVID pandemic in the first phase in the state of Assam. And in the last slide. Yeah, so these are some of the glimpses of the work that we have done. Some of the areas, moppings, and I'm not going into that. Maybe Dr. Deepak will speak during the discussion part. where we have found the mopping practices itself needed, and a lot of effort have been done to improve the mopping practices, because those mops were basically sources of microbiological contaminations. So maybe he will talk about that during the discussion part. Thank you so much.
Thank you, Saman, for that presentation. And thank you to all of our case study presenters today. We'll now be starting the Q&A session. We have 15 minutes left for this. So I welcome you all. If you wish to unmute yourself and speak, please do raise your hand first and we'll call on you. You're also welcome to put your questions in the chat. I see that we have a few in there already. Lindsay, I think you were the first one to have your question in there. I'm going to invite you to unmute in a second. But first, I would like our case study presenters to reflect across the other presentations that we saw today. So for our team from India and our team from WaterAid, if you'd like to reflect briefly on Guy's presentation to think about these cost benefit assessments when you've had these workshops with government and you've presented to local stakeholders, how does that kind of information play into these workshops and discussions that you've had with local government? What do you do with this information? And then Guy, I'll go to you next if you want to reflect on the cost data that was presented. How might you use some of this information if you were to replicate these models, for example, outside of Africa to look at a similar model in Asia, for example?
Yeah, can I go first? I was curiously reflecting on the first case that Guy made, and I believe that the excellent work that Guy and his team had done in terms of cost benefit analysis are really very important. So in India, we have this health technology assessment, which specifically works in terms of developing the cost benefit and cost effectiveness analysis. And the budget impact is another work that we do to understand that what would it take if there is a new technology, what are the cost impact. But this is something which is which are developing. If we can do the work well and present it to the policymakers, they are definitely very well taken. But what is important is to also generate capacity to do such exercises more rigorously and making those exercises policy relevant. And Guy's work has been an excellent way by which he could make his work very, very policy relevant. So congrats, Guy, on that.
Thank you. Anyone from the WaterAid team, would you like to weigh in?
I'm slightly biased because we've been working with Guy as WaterAid on these reports, but I think, yeah, I think what we're seeing, especially at district and facility level, is that often these sort of operation maintenance costs, as both case studies showed, aren't considered in planning and budgeting for Washington healthcare facilities. So I think all angles are needed to take this sort of discussion forward for really, presenting the case of why we need to be considering all aspects of the costs that need to be covered under Washington healthcare facilities. I think as well, depending on the audience and who you're speaking with, it also is really helpful to have some of that data to sort of show both cost savings, but also the benefits of putting in the, finding the financing and ensuring that it's coming down to the district and facility level to ensure that we can keep these services running. So I think there's a space for both these studies to really kind of build the case and continue to speak to the right stakeholders for increasing funding and financing towards Washington healthcare facilities.
Great, thanks. Guy, would you like to weigh in on the two costing studies that were presented?
Yes, well, thank you. That's very interesting to sort of see good quality cost information coming. And I think that we really need these numbers to be able to use at global level for more advocacy. I think we will find that the costs coming from detailed country studies will be more than the ones that were published by WHO and UNICEF in the Chaitkin article, and the data that we use, which is just under $1 per capita per year, which I think would be a little too optimistic. We've got to remember that it's, there's obviously the big investment, but we've got to ensure continued training, monitoring, supervision, studies, audits, and so on to ensure that behaviors of healthcare staff sort of remain to be practiced. Otherwise, it'll be all for nothing. Your second question, Darcy, is replicability of a model elsewhere. The model I presented is sort of easily replicable in any region. It does focus on the sort of direct healthcare costs. In more developed systems, there'll be a whole host of other costs related to healthcare acquired infections. So it may not be replicable to, say, Europe or America. We've already applied it in Cambodia through the request of WaterAid, we found it quite successful to use it there. It is just key to be able to gather the data inputs that are needed and have relative confidence on those. So being able to review the paper and the draft paper with some local experts is really important part of it. Thank you. Back to you.
Perfect, thanks. I'll take some questions from the chat in the order that came in. Lindsay, I see quite an extensive question from you. Rather than reading it out, I'm just going to invite you to unmute and ask it yourself.
Thanks. There are two questions. These are both for Guy. Guy, first of all, on calculating the cost of illness, were those, is that like a standard accepted methodology that's used in the economic space? I see those three calculations for productivity, mortality, et cetera. Just curious how those specific calculations came about. And then secondarily, and it kind of sounds like the way that you're discussing this, that we can think about this as one larger body of work. But when it was originally published, we had the World Bank article, and then we subsequently had the WaterAid article that came out using the same methodology. Do you feel like there was anything that jumped out as an anomaly when you were doing that work, comparing these 14 countries? Or do you feel like kind of the same message and the same takeaways can be concluded from these two studies we can use in our advocacy? Over. Thanks.
Yeah, thank you, Lindsay. Well, to answer briefly, yes, I mean, it does follow fairly standard methodology. The methodology obviously depends on what data sources you have and the number of variables you include in your model. We included sort of as few variables as possible because we knew the data would not be available. So it does take a few shortcuts, but we try to be conservative. For example, on productivity, we're not going to know what people would be doing with their time. We have to use sort of average employment rates and average wages and those types of variable. But if you did a study in a country, you could do a survey and find out those things through primary data collection. On the so anomaly question, as you saw from the results, that there's quite a variation in the cost as a percentage of GDP and the health cost as a percent of overall health expenditure. There's quite a variation because the inpatient admission rate varied a lot between countries by a factor of up to 8 times. So Mali had an extremely low inpatient admission rate per 1,000 people, and Malawi or Madagascar had higher, which meant that that's really driving the results. But I don't think that other than that we had any great surprises. I think what we're lacking is good quality cost information on what it costs to treat using different types of drug for different types of infection. That is hard to get for an international study, and that is why I recommend more detailed country level studies, which would get more credibility amongst national stakeholders. Thank you.
Perfect, thanks. We'll take a question from Kabede in the chat. I I think this is directed to you and your team if you and Deepak want to handle this question. Kabede asks, do the risk analysis consider to prioritize intervention needs and ranking in the short term, medium term versus long term? And then how about consideration for capacity building and behavior change interventions, engaging patients, staff, community, other stakeholders? How did you factor this into your costing?
Yeah, so maybe I'll let Dr. Deepak answer this wash fit thing because he pioneered that. Maybe I will then take the second part. Dr. Deepak.
Thanks. It was toolbox, not wash fit. It was based on wash fit, the indicators. So it was toolbox 1, 2, and we along with some of the colleagues from Soapbox Collaborative and Share, especially Professor Wendy Graham, we have been working for last decade on assessment of wash in healthcare facility. One of the important thing that came out, in fact, whether we did this work in India or in Bangladesh, was in India, the cleaners and moppers are on contractual job, and as soon as they get something, they immediately move out. So one important thing that was in fact implemented in Gujarat was induction training for all cleaners and moppers, and that was undertaken by IIPH Gandhinagar. Now, having said that, there are two important stakeholders: one, the community person; second, the cleaners, moppers, and the healthcare facility managers. Unfortunately, my observation is that wash in healthcare facility is their last priority. They have got other priorities, but when we really talk about maintaining optimal wash, it doesn't take care really. So there is a systematic need or requirement for engaging the policy planners and the program managers to ensure that this is an important forte. And our observation says that there are no protocols for cleaning, mopping, or even for change of mops. And therefore we need to have such interventions where long-term behavior change actually can be implemented. Efforts are being done, but these are isolated. But it requires a sustained work and engagement, not only with policy planners, but also with the different stakeholders, including patients, their relatives, and of course, the cleaners and moppers. So for sure, this is something which requires, because even in Assam, they have got good healthcare facilities in terms of infrastructure, but the manpower or the softer skills which are required are not there. So it is an important thing. Thank you.
Great, thank you. We've got just a few minutes left in this session. I'm scanning the chat. Ute asks, is the costing tool available? I see that Kyla has provided it. We also will be sending out all of the resources that are mentioned in this session in our newsletter that will come out in a few weeks, so keep an eye out for that. If you haven't been receiving our newsletters, some people have said that there's a change in their spam filter settings, so do check your spam folder to see if the newsletter might be routed there. In the last 2 minutes of the session, if I could just go to each of our case study presenters, and if you could sum up the one bullet point for all of our policymakers and practitioners on the call, what would you like them to take away from your case study that they might be able to apply in their work? Kyla, you show up first on my screen if you or someone else from WaterAid wants to start.
Just checking if Fraser wanted to take this one. Fraser, over to you.
Sure. The one key point, I guess, from our experience would be focusing on participation in those costing processes adds a huge amount of value in terms of getting people on the same page, the same understanding, regardless of the actual results of the costing and how they're taken forward. That can really contribute towards renewed momentum and collective commitment to improving WASH in healthcare settings.
Perfect. Thanks for sharing. Deepak and Soman, you show up next on my screen. One key takeaway?
Yeah. Dr. Deepak, would you like to go for that, or do you want me to do that? Okay.
Go ahead, Soman. Go ahead, Soman.
Yeah.
Thank you.
Thank you. So maybe one important takeaway that were there is to have better capacity building for a bottom-up planning. Currently, and I think I would resonate or echo what Dr. Kyle has mentioned in her talk also, that most of the time those planning were done driven by political, or Fraser probably has mentioned that were driven by political considerations, and are very top driven. So how do we develop the capacity for a bottom-up planning? That is important. Now, these are in our guidelines, at least if I can talk about Indian scenario, these are in our guidelines that we need to have bottom-up planning. So on paper, we are doing that. But developing capacity to understand where the gaps are and then preparing action plan based on that is what were the important lessons from our work. So again, like, untied fund and everything exists, but how do we make best use of that? That is my key lessons that we have had from our work. Thank you.
Great, thank you. And Guy, I'll leave it to you for the last lesson.
Yes, well, to keep it very short, I would say to any manager of a healthcare facility with inpatients, I'd say you can save costs to yourselves, and you can save illness for patients and your healthcare workers by investing in WASH, IPC, and safe waste management practices.
Great, thank you. Thanks again to all of our case study presenters for joining us today. We're excited to share these lessons with you. Thank you to everyone who interacted with the chat and who joined us today. We'll close out the session, but do stay tuned for follow-up in our newsletter to share out some of these resources. Thank you, everyone.
Thank you.
Thank you.
Yeah. Thank you. Bye.